Hello everyone and welcome to episode 17 of CCLG's Research Talks for Parents and Public. I'm Ellie Ellicott and my job is sharing research with our supporters. So let's start with some housekeeping. We'll be holding a Q&A session at the end of the talk, so please do submit your questions whenever you think of one using the Q&A button at the bottom of your screen. If you would like to use the chat function, please make sure that the to drop down is set to everyone or people might not see your message. This webinar is being recorded and will be available publicly on our YouTube channel, and we'll send out the link when it's ready to watch. So this month's talk is called What Improvements Are Needed for Young People's Cancer Care and is led by Professor Dan Stark. Dan is the Professor of Teenage and Young Adult Cancer Research at the University of Leeds and is a consultant in Leeds treating sarcomas and teenagers and young adults with cancer. He's a fierce advocate for TYA research and patients and designs clinical trials that study quality of life, psychological wellbeing, and translational research. Dan also leads multiple groups that support research into young people's cancers. So without further ado, I'm going to hand over to Dan.
Thank you very much indeed. And thank you ever so much for joining this webinar this evening. I shall share my screen and get started. So this is my talk for this evening. I'd like to acknowledge the NHS Trust in which I work in Leeds and the university that employs me. I'd like to acknowledge the NHS and all the fabulous support that it gives to young people. I'd like to acknowledge the Teenage Cancer Trust and colleagues who supported the Young People's Cancer unit that we have in Leeds. I'm a relatively unusual fish in that I'm a medical oncologist, which means that I primarily train in treating adults with cancer, not children with cancer, but I'm an active member of the CCLG, and I've been interested in teenagers and young adults with cancer since I was about halfway through my training as a registrar in oncology, and I spent 2 of the 4 years training as a registrar working with adolescents, teenagers and young adults with cancer, and that's when I got interested in this approaching 25 years ago now. What I'm going to tell you about today, I'm going to tell you about what researchers are doing for teenagers and young adults with cancer and what the future might hold. I'm going to tell you some more about young people's cancer research, more about the current top research priorities in this area, and then have some time to answer your questions. So do please remember to keep those questions coming in. So who are teenagers and young adults with cancer? What are their characteristics? What are the challenges? A little bit of history of the issue, and to talk a bit about age and definitions a little bit, because you'll sometimes hear this referred to as teenagers and young adults, TYA, and you might otherwise see it referred to as adolescents and young adults, AYA, and I'll explain why that is and what that's all about. Very sadly, there's an increasing incidence of cancer. More cancers are being diagnosed per head of population year by year in teenagers and young adults, which in this talk I'm defining as young people aged 15 to 24, inclusive when the cancer's found. This places a very large burden on them and a significant burden on our society as a whole, because we still very sadly lose about 250 young people to their cancer every year. But we also see a lifelong disability of people living after cancer that began at this age range. In the past, the survival of young people like this with cancer was extremely disappointing. Through the late 1970s, early 1980s, it was extremely disappointing. But from the late 1980s onwards, we began to get interested in this as an area. Focus upon it as a clinical and research group working with patients and their families. And that focus and hard work improved what we were doing and improved the outcomes for young people with cancer. This work now needs to be maintained and enhanced further. The specific challenges can be summarized as medical challenges. Can we make a diagnosis quickly in a young person? Can we understand the disease that we're treating at the level of its biology? Can we understand the adverse effects that we're causing with our treatments? Can we the challenge to support the young person? Can we provide them with psychological support specific to who they are as a young person, with social support so they don't lose out on their peer group, and with support with specific things in their life such as fertility? And can we design health services to meet the needs of teenagers and young adults? Teenagers and young adults, and I like this word, it's not a word everybody uses, they're liminal as individuals often. Liminal means in a space between different things. They're no longer children, but they're not yet fully independently functioning adults. And that creates problems for keeping them in cancer treatment and in good services, in running trials and running research. We go back to the early 2000s, a friend who might even be on the call, I don't know, Maria Michelagnoli, a consultant in adolescent and children's cancer in London, pointed out very eloquently how neglected teenagers and young adults were in health services then. They were isolated. They were surrounded either by young children, bashing little trikes and trolleys into their shins, or spread out in adult cancer services, where the average patient sat next to them in bed or next to them in the clinic was 60 to 70 years of age. Not the natural environment of a young person, and a very significant problem. Teenagers and young adults get different sorts of cancers. Children get this set of cancers, about a third of them leukemias, another 10% are lymphomas, about a quarter of them are brain tumours, and then there's a range of others, including bone tumours. Teenagers and young adults get a slightly different distribution. They get rather more lymphomas. They get a lot of germ cell tumours of the testis or ovary. They still get a fair few brain tumours, and they begin to get carcinomas. These are the cancers that affect older adults. And if we compare that red box of carcinomas in teenagers and young adults, it's those carcinomas which dominate the cancers in older adults, which is why a lot of older adult cancer services or children's cancer services don't understand these teenagers and young adults very well. They're not the illnesses they are used to seeing, which makes the teenagers and young adults, whether they're cared for with younger children or cared for with older adults, on the edges of what clinical services do. Even if we say a teenager or a young adult has got a cancer of a particular type, and in this case it's a germ cell tumour, the biology of that tumour is not the same as it would be in a young child or an older adult. If you go down into the real differences, into the gene expression in these germ cell tumours, we can see a 13-year-old arrowed on the left side there, who got a form of biology of their cancer that was more typical of somebody twice or three times their age. And we saw an adult on the right-hand side arrowed, the green circle, who got a cancer more typical of a young child. So we have to understand the biology of these cancers and not assume that they're the same as older adults or younger children. This is an example in germ cell tumours, but there are literally hundreds of others of examples where the age is limited to a different tumour biology. The outcomes of teenage and young adults with cancer, and this is work from some years ago of my group, isn't the same as younger children or somewhat older adults. There are a range of cancers on the left-hand side here, where the chance of recovery is best in young children, in the middle in teenagers and young adults, and less good in older adults. And there's the smaller group, there's the group of cancers in the middle, where teenagers and young adults do better. They do better than somewhat older adults with these adult-type cancers quite often. And they do better somewhat than both younger children and somewhat older adults with ranges of brain tumours. But then sadly, with bone tumours, soft tissue sarcomas, carcinoma of the breast in women, and non-Hodgkin lymphoma, they get the worst of both worlds. They do less well than children, where children get those conditions, and less well than older adults. And this reflects the challenges that we see. The idea that we might care for teenagers and young adults in hospitals differently from young children or older adults is an old idea. It came around with the, in inverted commas, invention of the teenager in the 1950s, with all of those American movies about the invention of the teenager. But then it's developed in healthcare in Europe more formally more recently. So ENCA, Work Package 17, was one of the first international projects in teenagers and young adults with cancer that I got involved with. That was in 2010, 2011. And TIAC followed that in 2016. The professional societies got interested in the mid-2010s, 2014 and onwards. and the large-scale research and strategic international work began in 2022 with Strong AYA and in Jane this year. And we can show steady progress in papers like this one in the top right-hand corner, since we've been working in teenagers and young adults in providing specialist services for them. The very first specialist service for cancer in teenagers and young adults in the world, as far as I know, was in London at the now closed Middlesex Hospital in and around 1989. At that time, we defined TYA in the UK as patients from usually their 15th, sometimes their 13th birthday through to 24 years. And the aim in the UK, which was picked up in Australasia and picked up in France to some extent, but developed in parallel in France, was creating services for these young people that were adaptations of children's models of care, to adapt children's models of care to young people. Adolescents and young adults is an older age group, and this is the classification that North Americans and Europeans have chosen. And that's aimed not necessarily at creating clinical services, although it has created some clinical services. They began rather later, and they aim to create research initiatives and collaboration between children's services and adult services. And they began to develop their AYA services rather later. The NHS provides standard things, thankfully, for teenagers and young adults with cancer. The NHS in England, and there is related in Scotland and Wales and Northern Ireland, provides a service specification. In any one specific hospital, what care are they supposed to provide for teenagers and young adults with cancer? And how do we hold them accountable for doing that? They're part of operational delivery networks, so regional groups providing these services and making sure they're of good quality. And they represent the national picture at strategic groups, such as the Clinical Reference Group, advising the NHS. But the charity context is critical. And in the bottom right, you'll see an old snap from the Teenage Cancer Trust website and the Teenage Cancer Trust Blueprint of Care. And they and other charities have been critically important as we've been going forwards in developing age-appropriate environments of care and age-appropriate models of care. So the care that's provided in these NHS centres is quite often defined by the Blueprint of Care of the Teenage Cancer Trust, but quality assured by the NHS, that it has larger hospitals, principal treatment centres, smaller hospitals, multidisciplinary team meetings where X-ray specialists, different other doctors, experts on the biology of the tumour all come together to discuss cases, together with social workers and youth workers, places of care, information and support, regular review of each other's services to help each other make them good, and obligations to deliver clinical trials and have their quality of what they do measured. Elsewhere, there are different things. In Australia, there are services a bit like the UK. In the US, there are services that are more marginal to hospitals. And in Europe, this is really just beginning. Continental Europe, this is really just beginning. And if you're interested in reading about it, this, I think, is a really good paper, which I was lucky enough to be part of, which talks about adolescent and young adult services and begins to get those developed in Europe. The services in Britain, in England, for teenagers and young adults are just about to undergo a further round of improvement, we hope. The Department of Health and Social Care has put in place, beginning in 2023 and then relaunching in 2025, a task force which covers children's and young people's cancer services and wants to bring together what we want to do better in the NHS in England for the next 10 years, set the next strategy. This is looking at things like DNA testing genetics and genomics in cancers and in young people, and using that to guide treatment, to change side effects and provide more effective treatments, better pathways to diagnosis, better research and better innovation from that research, and better data, better information within the NHS about which cancers young people are getting, how they're being treated, what's working, what isn't, what we should be studying in research. And I'll come back to that. So that's the kind of background of my talk today. Between 2016 and 2019, funded by charities and supported in a structure of an excellent charity called the James Lind Alliance, a group of people, not including myself, did an enormous amount of work to generate a set of priorities for teenage and young adult cancer research. It was an amazing process with hundreds and hundreds of patients and their loved ones. Met dozens and dozens of clinicians and researchers, created many hundreds, almost 1,000 ideas for what should be research priorities, and rigorously whittled them down to these 10. Psychological support, reduced late effects, access to clinical trials so that people can get the current best treatments and can continue to try to find treatments when proven treatments are no longer effective. Improving early diagnosis, supporting a young person once we unfortunately acknowledge together that cancer is going to be part of their life for the rest of their life. How we look after young people who don't come into the big regional hospitals in the big city with the big university hospital. How we get young people back to education or work. How we support the people remaining once a young person dies, their loved ones, their friends and acquaintances, and of course their families. How we follow people up after their cancer, which balances the stress and psychological burden of coming back to the cancer clinic in order to be checked, with detecting if there are problems quickly, whether those problems are with the cancer or with a problem with the treatment. And can we target treatments? Can we move away steadily from chemotherapy and radiotherapy, which damage the DNA in cancer cells and make those cancer cells therefore die, but which kill a lot of non-cancer cells, healthy cells as well, and move away to saying we poison this specific part of this cancer cell, and as a result the cancer cell dies, but hardly any other parts of the body cells are damaged as well, these so-called targeted and other treatments. So these were the research priorities, and these were shared with the funders and the sponsors of research. And this is due an update, and an update is planned in the next year or two. When we look at the challenges of the research, you're deliberately not meant to be able to read this. It's Lorna Fern's work, it's not mine. She's chairing the Teenage and Young Adult Cancer Research Challenges Group, and she's setting a strategy to address these challenges. And I just wanted to tell you as a group that this is happening, just so that you're aware, that in a strategic manner, we're identifying the challenges and making a strategy to address them. Let's tell you some recent findings from key teenage and young adult cancer research. So universities, together with the NHS and charities, led from University College Hospitals in London, managed to obtain large-scale funding from the National Institute for Health Research to run the Bright Light study, and then more recently the Bright Light 2021 study. The Bright Light study you may have heard of. This demonstrated good outcomes for teenagers and young adults for cancer in general. It gathered together just over 1,000 teenagers and young adults were diagnosed with cancer between 2014 and into 2015, and followed them up for about 3 years. It showed that the patients who had the most difficult cancers, who then went into the very large principal treatment centre hospitals and got their care there, did okay. They were the very illest at the beginning. They recovered quite well. They were quite likely to recover fully from their cancer, and their quality of life got quite a lot better. The group of patients who had a cancer that wasn't so complicated to treat and stayed at a designated hospital, a more local hospital to their home, they were the least unwell at the beginning with the least impaired quality of life. They also had a good chance of recovery, but there was a group who had problems. The group who had problems were those who had part of their care in the big hospital and part in the small hospital, the so-called SUM group. Some specialist care, some less specialist care. They had problems. They had a disappointing chance of recovering from their cancer, a disappointing improvement in their quality of life, and quite a lot of ongoing problems were demonstrated. So therefore, we took that finding forward into the cancer service specification for TYA, and we tried to put in place a thing called joint care, where we forced the hospitals to work together over these young people who needed some care near home and some in the large hospital. And when we replicated those findings in the Bright Light 2021 smaller study, We were pleased to see that that inequity for the sum group appears to have gone away. We're still analysing that, but it appears that the Bright Light study, followed up by a change in policy and then replicated later, shows a positive trend. The STARS study is a separate study that I was lucky enough to be able to lead with Owana Linda and also colleagues at UCL and others. This looked at getting back into the workplace, back into relationships, back into friendships and communities after young onset cancer. And the dominant interesting finding here was how positive and common it was for young people after their cancer to go into adult education, back into education, rather than straight into the workplace or whatever. This is a fascinating finding that we're exploring further, but really it was almost 10 times more common for a young person living after cancer to go back into education as it is in the general population of similar demographic characteristics. Isn't that interesting? And then there's other excellent research you can look at with key recent findings, which was initiated by the charities with support of the NHS and universities, such as the North Star project, which is linked there, which has shown the ongoing burden of mental health, marginalised group, and the ongoing need for better bereavement support. I'll move on. Some ongoing research. REN3. REN3 is led by Lorna Fern again and is looking at trial age criteria. One of the problems is a young person wants to enter a trial, but the trial isn't designed so that they're eligible. They're 17 and 11 months, they can't go into the trial, or they're 18 and 6 months years of age and they can't go into the trial because it's been designed without them in mind. So Lorna is using the REN3 trial to look at these criteria. We discovered when we challenged these criteria and when the funders of research challenged a trial finishing saying you can't go in if you're over 18 or you can't go in if you're under 18, when we challenged it, most of the trials were redesigned with a more appropriate age range. So Lorna's looking at whether we could do this further. The PROTECT study's just finished accrual and is in follow-up, and it's looking at which cancer treatments have the current modern cancer treatments have the biggest impact upon somebody's ability to be a parent in future, and how we could measure that better during the treatment rather than just identifying it years later. And the Strong AYA project is looking at which outcomes we should measure. It's a European project looking at measuring quality of life, measuring clinical outcomes, quality of care, and then measuring that from young people reporting it and getting it from the hospitals, comparing it between different hospitals around Europe. In the UK, that's Leeds and Manchester, but it's being compared with Paris in France and Lyon and Amsterdam and Warsaw and Milan, and seeing which ones have the best outcomes, and then using that data to improve outcomes and understand why things change. Recently starting 2 projects in Europe again, PanCare for Aya, which is looking at how we could monitor teenagers and young adult cancer survivors. Children get relatively structured monitoring for the rest of their life after cancer. Teenagers and young adults don't at the moment, and that's because there is not enough data and not enough consensus about how that should be done. So PanCare for Aya is going to sort that out, we hope, and that started this year for 5 years. And then Predict Aya is saying which young people get which side effects later on after their cancer. Can we predict that as the cancer is treated rather than waiting to see which side effects late happen, which late effects and disabilities develop, and dealing with them then? Can we predict them? So PanCare for Aya is led in the Netherlands with UK participation, and Predict Aya is led in Sweden with UK participation as well. Moving on, getting young people into clinical trials. For those that aren't familiar with clinical trials, we've got the trials that look at treatment A versus treatment B. These are so-called late trials where both treatment A and treatment B look pretty promising. They look like one might be maybe slightly better than the other, or they may both be the same, but we haven't got data that's head-to-head. We haven't got the so-called level playing field that the politicians and journalists like. So we run a randomized trial as a comparison, a late phase trial. And then at the end of that trial, the one that wins, treatment A or treatment B, becomes the NHS standard in the years that follow. Or early phase trial, where we have a group of patients where we don't have a treatment that we think is good, nearly good enough, and we need to develop newer things, but we need to test them. So we need to test a newer treatment. This is an early phase trial. So somebody develops a new medication, a new way of giving radiotherapy, a new way of doing an operation. We need to test how safe it is and how we should exactly do it. So that's an early phase trial. Over time, there have been too few of these trials for young people, teenagers and young adults, but in the last 5 years, it has improved. We are improving the number of trials that are focused on teenagers and young adults steadily from the low 40s to the high 50s in recent years. Most of the trials are about specific cancers in more and more detail. Trial about leukemia, trial about brain tumor, trial about bone sarcoma. We're trying to encourage them to think about the teenagers and young adults and pull that information out, studying it separately. People often say when we talk about new treatments, why does it take so long to develop a new treatment? And that's about people with lived experience seeking out trials and joining them and helping us to design better trials, working to make trials more attractive. And again, I want to cite Lorna's amazing work from 2014, the 5 A's paper, which is looking at how we make trials designs more appropriate, people more aware, trials more available, better access, and trials more acceptable in their design. How do we make trials more acceptable in their design? Well, we try and use an innovative trial design. For rare cancer, we can run multiple simultaneous trials. We can use big data. We can use NHS data, data collected from electronic health records, to mean that trials can be smaller. We can use different statistical analyses of trials, so-called Bayesian designs, and we can look at using different ways to measure the outcomes in trial, using blood tests to measure the outcomes rather than just purely imaging, using new blood tests such as microRNAs to do this. We can make trials better by better engagement with the public, to make the research better by public and patients getting involved in the design and implementation of trials, to make them better, more impactful, more useful to patients in future. The Bright Light study that I mentioned earlier was at the very heart of doing this, and the Bright Light YAPAs showed us a lot of ways how we can improve patient and public involvement for teenagers and young adults in trials. And if there are any people who took part in that, thank you very much indeed. We're now working across a European group, Youth Cancer Europe, who are proving a huge group who are training dozens and dozens and dozens of young people across Europe to be advocates and to support research and to design and run their own research. And one of the next steps here I'm going to come on to now, which is a recent innovation, the idea of a living laboratory for children's and young people's cancer in the UK, which we're in the final stages of agreeing, setting up with the CCLG to set up a children and young people's living lab. So a living lab is a digital infrastructure, a website, embedding the best software to support discussion, networking, co-creation of research and service innovations, experiments, and to disseminate the findings of research. And a living lab is one infrastructure. But within this infrastructure, you have a number of nodes. And we'd like a node on how we get young people back into society after their cancer most effectively. And we'd like a node that looks at how the charities work on that, the NHS works on that, but can we coordinate their work together? Of course, then if we've got a node and we've got an infrastructure, we can put further nodes in the same infrastructure. And this can mean that young people who are interested to take part in this, parents who are interested to take part in this, researchers, healthcare professionals, when they go to the living lab to take part in the node that they're interested in, they can see the other things that the other nodes are doing in outline, and they might be able to participate or add value to those. Then, of course, people can move across the nodes, and we can link the nodes and begin to make the people, the expertise, the work and learning be shared and develop together across specific nodes. And then eventually, in due course, we can catalog the individuals create a list of individuals who are interested in this. So we stop saying things like, oh, we want to make a consultation with young people and their parents and carers about how to design the next trial. Let's all go out and find some. Yeah, we should know who we've got around already and know where we might access them. That'd be very useful. To talk about some wider initiatives, well, the Children's Cancer and Leukemia Group is just rebranding as the Children's Cancer and Leukemia Group, Children and Young People's Cancer Association, and that reflects its increasing interest in teenagers and young adults with cancer, which is very helpful to us. The Experimental Cancer Medicine Centres initiative, which is Cancer Research UK and a range of other partners, is focusing on teenagers and young adults at the moment on issues like how do we early development of drugs, how early do we consider the impact upon being a parent in future. The Association of Medical Research Councils is just putting together the wider research collaborations and research groups. And we have a teenage young adult and germ cell group there, which is working on early onset carcinomas, federated learning systems, clinical trials, patient and public engagement, making that equitable of people who otherwise research is poorer including, and gathering together better data, developing the next generation of researchers in this area, and developing leadership skills for people who are setting out in this area, and also helping to develop for us more European collaboration in this area. So, what do we need to do? Drawing this to a close. Teenagers and young adults get different diseases from children or older adults. We have to understand those diseases. We have to understand them, not just how they develop, but their biology once they've developed, and therefore which treatments will work for them. They may respond differently to therapy, and we have to understand that. We need to work together across the different professional teams that care for patients of different ages and study those health service designs in health service research, such as Brightlight and Brightlight 2021, to make that work better. We need to make sure that we understand that if we're designing a clinical trial for a teenager, older teenager, or a young adult, it's different from designing it for a young child, because they have to go along with what you want to do more than a young child does, particularly a small baby who has less say in which medications are given. Their parents advocate for them, but the young person has to agree to the trial design if they're an older teenager or a young adult. These are rare cancers with small patient numbers, so hard to develop new drugs for, because drug companies are commercial organizations and want to sell a lot of the drugs that they develop. That's how they recoup their research costs. If the research costs are the same for a drug that's going to be used in 1% of patients versus 20% of patients, they'll put more energy into the drug with a bigger market, because they're commercial organizations. If they didn't do that, they would cease to exist. There's a lack of data to understand how these outcomes occur, and we need to build more and more and more with initiatives like the Living Lab of the perceptions of young people and understand the perceptions of clinical teams. Thanks to Dr. Sarah Stoneham, who's taking over the chair of the UK Clinical Cancer Research Collaborative Group from me right about now. So thanks to Sarah, and good luck in that role, and I'll be around to support her for a while longer. What to take away? Adolescents and young adults are not children. They deserve a different level of, they're more independent, and they deserve a voice and a choice in their own personal care. Children's cancer services improved through full centralisation. Every child with cancer came to the big hospital in the region. Teenagers and young adults with cancer, that's not going to be feasible. They don't necessarily have the parental environment or the support or the finances to do that. So the key question then becomes, in a different system that has local hospitals and large regional hospitals, can we gain the benefit of the specialization? Can we design clinical trials without necessarily mandating that all young people have to travel 60, 80, 100 in Scotland, 200 miles every time they need a bit of cancer treatment or a bit of cancer care? Thankfully, it's a good time to be in teenage and young adult cancer care because there's a huge wave of interest. Clinical services are very interested in this because they've got cancers that are getting commoner in young people, and they're interested in survivorship after young onset cancer. They're interested in the diseases that follow. So there are a lot of people, you talk about this in NHS hospitals. 15 years ago, everybody squinted at you. I wasn't very interested, but now they are. Specialist services are developing across the world for this. International research is booming in this area, including €30 million of investment by the European Commission in this area last September. There's a global initiative in this, taking what we've learned in some countries to countries that have different levels of resource and learning what they can tell us in return. And there's a funded infrastructure in Europe. But sometimes if you work in teenage and young adult cancer at the moment, it feels like an enormous wave of interest crashing over people like myself and Sarah and Lorna and others, and trying to understand where we're all taking it. It's great fun, but it is very challenging. Thank you very much for listening to me today. I hope it's been of interest. I've seen a few questions accumulate, which I'll be delighted to try and answer. I'll just leave this fascinating slide that Sarah Stoneham put up, her own recent talk on a related topic recently. Yeah, just talking about how we can work as a community, what we have to do, and I'll let people who are interested in how you make something that you want to happen be what actually happens. Leave this slide up for them if they're interested. This image up for them if they're interested. And thank you very much for listening to me.
Thank you very much for your talk. It's been really interesting to hear more about what's going on with TYA, and to be honest, I was quite surprised to learn that it was all so recent. It's quite surprising, really. It
is indeed.
Sorry, we do have some questions.
Excellent.
So I think I'll start with this one, just to see if you have any thoughts, and then we can possibly email those over. Do you know anything about the RIT trial for AML? Acute myeloid leukemia.
I'm not an expert in acute myeloid leukemia. So unfortunately, somebody who wants expertise in acute myeloid leukemia, or it's fair to say in a webinar like this, I wouldn't want to give particular expertise, expert clinical stuff on any particular illness, because it's so personal to the individual and exactly what's wrong with them. Yeah. And usually people's own teams of doctors and nurses have spent hours, weeks, months trying to find out all of this detail. And it would be easy for somebody like me to make that harder and mess it up, and very unlikely that I would add value. So talk to your own doctors. And if you're finding it difficult to talk to your own doctors, say that and try and break that down and improve that. Or, of course, all experienced and senior doctors don't mind if everybody's not getting on so well, if people take advice from other doctors as well, formally, through formal pathways, to find doctors and nurses who they find it easier to work with. First of all, though, talk to your own doctors and try and rectify any disagreements or problems yourselves.
Thank you. Okay, so this question actually came in about 10 minutes after you started talking, but it fits perfectly to your ending slide. The one before the ending slide. How can we address the challenges of encouraging pharma companies to fund research, including clinical trials, for rare cancers and TYA cancers? Because there is a lot of good primary research which doesn't get funded further.
Absolutely. There is a lot of research which either feels like good research and doesn't get funded, or good primary research that doesn't get taken further. Yeah. And I think there are two, there are many, but there are two that I'll bring to the front that we need to do about this. The first is that if a rare cancer trial opens and accrues really fast, even if it's a rare illness study, the pharmaceutical companies are delighted with that and very happy to continue to maintain further infrastructure in that area. So if we can make these trials a great success, yeah, then the pharmaceutical companies will follow their noses and we'll do that. If we can't make the trials a great success, they'll take that as a soft indication that if they launch the medication later on, people won't be that interested in that either. So the market won't be so very great. Yeah. So we have to make a success of these trials. I've seen huge variation in this. I've seen trials, well-meaning trials open in rare cancers and them not be successful in accruing. And equally, I've seen trials open in rare illnesses that have accrued at 10 times the rate anybody was expecting. Yeah. And that's about clinical networks and patient networks. One of the ideas that often gets talked about, but hasn't got done yet, but does get talked about, is the idea that patients and their families might have somewhere that's anonymized, but links to medical teams who are developing new treatments. where they can put a couple of lines about the quandary that they're in with their cancer. I live in this part of the world, but the illness that we're battling with, or that we're working to overcome, is this illness. We've had these things done so far. I can be contacted informally through this indirect link, but an indirect email link of some sort, or an indirect link. If you've got any research ideas that might fit me, would you contact me? Yeah, it's just an idea. It's challenging. I see. It's not normal. It's not usual. It's not the traditional way of doing it through doctors and through your own hospitals, but it might have a place. It's interesting to think about. The second thing that we need to do with pharma is we need to be very clever in how we design these trials. We need to get the best statisticians, the best clinical trials units, cutting edge statistics, cutting edge trial design. Yeah. And in fact, young onset cancers have always done that. Yeah. And therefore make these trials as efficient, as cost effective to answer the question as they can possibly be. Yeah. And so there are multiple other answers to that question, but those are the two things I'd put at the top.
They sound great. I mean, the idea, I've not heard that before, of having a sort of like an area like that, but it certainly sounds like something parents would be very keen on. Okay, so I have another question. So you mentioned that the James Lind Alliance, the priorities would be updated. What would that look like? Will you be developing new priorities?
Yeah, so there's just a lot of conversation about what that might look like and how it might be done. I think it's a great idea. It also fills me with a slight feeling of sickness in the pit of my stomach because of exactly how much work it was before. Yeah. And those who were really close to it, I suspect, are still lying down in a darkened room from 2019, since 2019. So it's because it was a massive undertaking. But joking apart, there is an idea that we would refresh it, and there is the thought that we might refresh it through the living lab that I described. Yeah, that might be a means through which we could refresh it efficiently, effectively, accounting for modern for the value of video conferencing and all of that, minimizing the number of large-scale meetings where you have to get everybody at great cost to a venue and spend the whole day there, and all of that. So we're thinking about that, but basically it would build upon what you did before. It would take those ideas, take the longer list of ideas, innovate around new things that are brand new, which there might be some, but they're probably at that level of strategic objectives. There won't be that many really things that are new under the sun. You know, there's little that's new under the sun. Yeah, particularly if you think about things that people were thinking about years before or whatever. And then build a consensus. And then this next time, I think it's important to turn them into what researchers would call research questions, which are quite tightly defined things. People probably know that from their own professional or lived experience. So research questions can be good or can be bad. And what we didn't do so well with the James Lind Alliance ones before was turn them into truly answerable research questions. And that needs to happen as well.
It certainly sounds like an exciting yet possibly terrifying time for you. I think I have one last question. So long-term mental health support can be a bit hit and miss, and some might say is constrained by the NHS's financial pressures. Do you see any cause for optimism in this area?
There's quite a lot of optimism in terms, and quite a lot of innovation and development in the provision of mental health services. The huge problem in the NHS at the moment with its provision of mental health services to its patients is that its healthcare professionals are providing a lot of care to the doctors and nurses in the hospital for their mental health after the pandemic. Yeah? So still, I think in a number of hospitals, about a third of the capacity for mental health provision for not for people who've got mental health problems out in the community, who've got schizophrenia or bipolar disorder or major depression or panic attacks or whatever. They've got their own services out there. But if we look at the provision of psychology and psychiatry to the hospital population of patients, the mental health of the healthcare professionals at the moment is so poor that a lot of the psychologists are providing care that keeps the doctors and nurses at work so that they're there for the patient. And that's impacting upon those same psychologists' hours in the working week to provide care for the patient. So if I could make this a small plea for what you all know, because you're all on this call and you all know, for mutual working and support and a kindness and affection from the doctors and nurses to you at all times, and from the patients and their loved ones to the doctors and nurses at all times. What to you might seem like a passing comment, quite impactful for those doctors and nurses if they're a bit fragile. Yeah, and that would get us more mental health support. Then we need to get into apps and other positive technological solutions to these different things. Yeah, and if we can get into all of that, we can weed all of this stuff out and sort all of this stuff out so that the people with the biggest problems have got the most care and the people with problems that can be dealt with in other ways. And we've got to get our overall nation back on a level footing, haven't we? Yeah, after COVID and everything else.
Certainly a tricky one, a bit of
yeah, so it's important to get it right. I see there's a comment from a therapist there just coming on the thing.
Yes, so they would like to know if there is any research around how complementary therapy can support children in TYAs with cancer.
There's quite a lot of work on, depending on what definition you're using, there's quite a lot of work on complementary therapy. Yeah. And depending on what definition of it you're using, there's a lot of different things that are done. I think that you will understand as a complementary therapist that sometimes the medical services, there are tensions between the medical services and complementary therapy services. But I think those are getting less as the conversations continue, and there are lots of good opportunities to develop things together. There's very good research that I've seen on acupuncture. There's very good research I've seen on aromatherapies. There's very good research I've seen on meditation and hypnosis. So I think these are things that are very, very interesting. They may or may not be, Paula, in what you're defining as complementary therapy. And excuse me if I'm missing the mark, but these are things that I've seen very good research about.
It's quite exciting. It's not new stuff, but it's becoming more to the forefront, isn't it?
Yes, I think so, and to be encouraged to do so, but to be held to account as well when they do so. Yeah, so that what they do is right, and is rigorously assessed and rigorously evaluated, because just because a treatment that's given in the NHS could be harmful or it can be beneficial, a treatment that's complementary can in theory be harmful as well as potentially being beneficial. So we just need to test things carefully.
Definitely. Paula has asked if you had any specific research that you could share, but I could, if you're happy, email her later.
No, absolutely. I'm not right across all of this stuff. I was just recalling somewhat off the top of my head what I remembered seeing recently. So any reply that I give to you, Paula, will be a little bit more general than perhaps you're expecting. But nonetheless, I hope I can help.